Hello, everyone. My name is Alduber Benitez. I am a student from Herzing University, psychiatric mental health nurse practitioner. Today, I'm working at the outpatient mental health unit. I'd like to discuss how I would address a crisis involving a young postpartum patient during her fourth follow-up visit. Clinical scenario summary. This is a 19-year-old married female, recently postpartum with a 2-month-old infant, accompanied today by her husband. She presents with a dramatic change in appearance, including provocative clothing and heavy makeup, which is a departure from prior visits. She exhibits pressured, loud, tangential speech and is fixated on a video series about aliens. She expresses delusional beliefs that her infant is an alien and must be taken to the desert and left on a mountain to be retrieved by aliens. Although she denies suicidal or homicidal ideation, she is clearly experiencing disorganized thinking, delusions, and impaired judgment with a potential risk to her child. Her husband corroborates that she has been acting differently and states he is afraid to leave her alone with the baby. Immediate priorities. 1. Patient and infant safety is paramount. The presence of bizarre fixed delusions involving her infant, even in the absence of explicit homicidal ideation, constitutes a psychiatric emergency. Her belief that she must abandon her child in the desert puts the infant at immediate risk of harm. I would not allow the patient or the infant to leave the office. I would gently but firmly engage both the patient and her husband to keep them in the room, while signaling for support from clinic staff or calling security if necessary. 2. Initiate emergency psychiatric evaluation. I would immediately contact the mobile crisis team or psychiatric emergency services for urgent evaluation. If not available, I would call 911 and request emergency medical transport, explaining that the patient is a 19-year-old postpartum woman in acute psychiatric crisis with delusional beliefs involving her infant and impaired reality testing. She is not actively violent, but her beliefs present a risk of harm to her child and possibly herself. 3. Mandated reporting and child protective services, CPS. In this case, I would also be legally mandated to contact Child Protective Services, CPS, due to the imminent risk to the infant's safety. While it's critical to treat the patient with compassion and dignity, I also have a duty to ensure the child is protected. I would explain to the husband, who has already expressed concern, that the baby will need to be temporarily placed in his care or with a safe guardian until the mother is stabilized. 4. Clinical documentation. I would document mental status exam findings, EEG, tangential speech, looseness of associations, bizarre delusions. O. Risk assessment. O. Husband's collateral input. O. Decision to hospitalize the patient and involve CPS. O. The emergency contacts made and actions taken to ensure safety, working diagnosis, and clinical impressions. This patient may be experiencing postpartum psychosis, a rare but life-threatening psychiatric emergency that typically develops within weeks of childbirth. While less common than postpartum depression, postpartum psychosis presents with delusions, hallucinations, disorganized thinking, severe mood disturbances, impaired judgment, and insight. These symptoms can lead to tragic outcomes without immediate inpatient stabilization, pharmacological intervention, and family support. Reflective summary. Crises like this highlight the importance of vigilant screening during the postpartum period and close observation for subtle changes over time. As a psychiatric nurse practitioner, I have a dual responsibility: to protect life and to treat illness with empathy. Even when patients don't express overt suicidal or homicidal intent, psychosis with impaired reality testing can still place them or others at serious risk. Establishing trust across visits also plays a key role in early identification of psychiatric decompensation. In this case, her change in appearance, speech, and thought content were all major red flags that demanded immediate action. I acted not only to prevent harm, but also to begin the process of stabilizing a young mother who is in the grip of a severe but treatable psychiatric condition. Diagnosis: postpartum psychosis, PPP, ICD-10, F53.1, severe mental and behavioral disorders associated with the puerperium, not elsewhere classified. Pharmacologic management. 1. Antipsychotics, first-line treatment. To manage delusions, disorganized thought, and impaired judgment. Options: O. Risperidone, 1-3 mg day, effective and often used in acute inpatient settings. O. Olanzapine, 5-10 mg day, sedating, helpful if insomnia present. O. Haloperidol, especially if severe agitation or risk to others is present. O. Quetiapine may be considered if sedation is desired. Note: choice of antipsychotic may depend on breastfeeding status. Risperidone and olanzapine are considered relatively safer during lactation, but still require risk-benefit discussion. 2. Mood stabilizers. Often used if patient has bipolar features or a prior undiagnosed bipolar disorder, commonly associated with PPP. Lithium is the gold standard for bipolar-related PPP, but O requires close serum level monitoring, O not typically used during breastfeeding due to toxicity risk to infant. Valproic acid, Depakote, or lamotrigine may be considered if lithium is contraindicated or the patient is not breastfeeding. 3. Benzodiazepines, short-term use. For acute agitation, insomnia, or anxiety, lorazepam, Ativan, 1 to 2 mg/PO may be administered. Should only be used short-term and with caution, especially if breastfeeding. 4. Antidepressants. Use only after psychosis is stabilized, as antidepressants, especially SSRIs, can worsen mania or psychosis if started prematurely. If later indicated, sertraline is commonly used in postpartum depression and is relatively safe during lactation. Non-pharmacologic management. 1. Inpatient psychiatric hospitalization. Essential and immediate due to O. Risk to infant, infanticide, or neglect. O. Risk to patient, disorganized behavior, poor judgment. Allows for 24-hour monitoring, medication initiation, and stabilization. 2. Electroconvulsive therapy, ECT. Considered safe and effective in PPP, especially if O. Psychosis is severe or refractory. O. Rapid response is needed. O. Pharmacologic treatments are contraindicated. 3. Psychoeducation and family support. Educate family, especially spouse, about O. Nature of postpartum psychosis. O. The need for ongoing monitoring and support. O. Warning signs of relapse. Involve family in treatment planning and safety monitoring. 4. Cognitive behavioral therapy, CBT, once psychosis resolves. May help in long-term recovery and addressing residual depressive or anxiety symptoms. Not used during acute psychotic episodes. 5. Breastfeeding considerations. Discuss the risks and benefits of continuing breastfeeding with prescribed medications. Provide lactation consultation and support alternatives, e.g., pumping and discarding milk if necessary. 6. Child Protective Services, CPS, involvement. Mandatory report due to risk of harm to infant. May lead to temporary custody assignment to a safe guardian, e.g., father, during hospitalization. Prognosis. With prompt intervention, most women with postpartum psychosis recover fully. Relapse risk is high in future pregnancies. Preconception planning and early postpartum monitoring are essential. Thank you for having me, and have a nice day. Don't forget to subscribe to this channel for more information about management psychiatric crisis.